city. This is 1-year-old boy presented to our OPD with the abdominal distension and he was in uremia. CT IVP was with him, which shows the bilateral hydronephrosis, right, left side gross hydronephrosis. Outside PCN was attempted, but it was dislodged, and we have also attempted, but it dislodged. So we plan it for the left pyeloplasty. So while entering through the umbilical port, camera port, what we found there, so inside we found multiple urine pockets, and this is the renal area, and some flex was also observed, most probably the PCN sites, and we thought to do this patient with the colonic reflection rather than doing the transmesenteric, as there was so many urine pockets was present retroperitoneum as well as intraperitoneum. It was very difficult to perform the further surgery through transmesenteric route. So we started thinking to mobilize this splenic flexure. Colon was mobilized. Still we can observe there was so much adhesion and urine pockets that create so much problem while performing the surgery. So mobilization of colon was done with care, as there was so many inflammation, so many urine pockets were present, and we can appreciate the kidney tissue as this patient is only CT IVP. So now medially we dissect, and what we see this whitish structure as the pelvis, which is not seems to be very ballooning. So we have taken the stay suture. Now we are proceeding to do little bit dissection over the pelvis and try to delineate the ureter, but surprisingly we could not delineate the ureter as in the virgin case. So we further do the dissection. Now a tubular structure was seen which is attached to the pelvis, so we thought this is the ureter. So carefully when we do dissection, it was seems to be not attached to the pelvis. So and no peristalsis was also seen. So we again try to look for the ureter, but no other structure, tubular structure was observed, and suddenly we found a pinpointed like over this. So we just thought this is the ureter, but it was separated from the pelvis, most probably from the pelvic ureter junction it was separated. Now we can very well appreciate its pinpoint. So this suggest, and there are so many urine collection was there near this pelvic ureter junction. So while performing the PCN, it was thought to be that pelvis, this ureter was dislodged from the pelvic ureter junction. So to free our one hand, we again take one more stay suture over the pelvis. Now we can appreciate, yes, this is the ureter. So now we plan to do spatulation of this ureter. This ureter is almost cut off from the pelvic ureter junction. So now we are going to do the spatulation of this ureter, and then we will start the anastomosis. We do the pyeloplasty. So taking the scissor in left hand, we start the spatulation. So we first half cut the ureter. You can appreciate this half cut of the ureter, and with the Maryland in the left hand and scissor in the right hand, we will further try to do the spatulation so that normal mucosa ureter will be seen, and then we will perform the anastomosis of this ureter to the pelvis. So we can now appreciate the normal ureteric mucosa. So further we will try to do the, now we have take this ureter stay suture over the abdomen, so that we can appreciate the lie of the ureter as well as pelvis, and we can do easily anastomosis. So after cutting the pelvis, dismembering the pelvis, we start the posterior anastomosis first. The anastomosis were performed with a 40 vicryl round body, and this posterior stitch was performed in a continuous manner. So now this posterior anastomosis is in continuous manner. Simultaneously we order for the digestion, which was 312, as the child is of 1 year of age, so 3 French and 12 centimeter length. So now with the help of suction we put digestion. With the first we insert the guide wire, then this is the digestion. So after putting this digestion, now we perform the further anterior anastomosis of ureter and the pelvis, again in the similar continuous fashion. So this is anterior anastomosis with vicryl 50 round body in a similar fashion as we have done the posterior one. We can do this anastomosis in an interrupted fashion also, but we generally perform in a continuous manner. So in this manner this anterior anastomosis was completed. Now this redundant pelvis that we have used as a stay, the extra part has to be cut, and the remaining pelvis can be sutured in a continuous fashion. So this pelvis was also completed suturing. So this anastomosis is now completed. Now the specimen of pelvis and as well as the part which attached to ureter was removed. Suction was done.